This video wraps up Chapter 26, Heat-Related Emergencies of OEC 6. We're going to look at the management of heat-related emergencies. Remember, we have 4 types of heat-related illnesses that we may need to respond to. We'll talk about the management of those patients. We've introduced some of these key terms in previous videos. Hyperthermia is essentially the core cause of these 4 illnesses. That is, a temperature, thermia, that is higher than it should be or above standard. So for management, of course we want to address any life threats right away. We can, part of our scene size up and part of our consideration is to move our patients away from direct exposure to the sun to a cooler area or a shaded area, but that protects us as well in terms of essentially scene safety. The further care just depends on what you assess and determine the particular illness is. Remember, heat stroke is a true life threat, so we may need to respond symptomatically, and that could include oxygen if a pulse ox shows they're less than 94%. So for heat syncope, that is that heat fainting, we can remove the person from the heat source, perhaps indoors or to a shaded location. Make sure that they're in a supine position, elevate the legs slightly, and that's going to return blood to vital organs such as the brain. What caused the heat syncope was they were hypotensive, and so this is going to assist with that. We can provide some supportive measures and possibly a cool drink. Now for heat cramps, we're going to respond in a very similar sort of a way, but that drink may also include some oral electrolytes. This could be just a sports drink like Gatorade or Powerade. It may be diluted 50% water and 50% sport drink. That can help somewhat with some absorption, or you may need to make your own. Just a 1/4 teaspoon of salt in a quart of water, a little bit of flavoring, and that can make it more palatable for the patient. Symptomatically, stretching or massage of where the cramped muscle is can provide some relief. For heat exhaustion, we want to make sure that it doesn't progress further into the life-threatening heat stroke. So we're going to move that patient to that cooler location. They're going to be in that position of comfort, supine, flat on their back, legs elevated. We're going to cool them off and remove clothing. And if a pulse ox is available, provide O2 if they're less than 94%. Hydration is going to be key in this case as well, similar to what we saw with heat cramps. Now, in most cases, this is really going to help that patient improve. Remember, what happened was their thermoregulation mechanisms were just incapable of keeping up with the environment, so we've addressed that by ideally moving them to a cooler environment and helping with dissipation of some of that heat. If they are not improving, may be indications that they're on their way to heat stroke. So we'll transport to a hospital for further evaluation and treatment. Really watch for that decreasing level of responsiveness that indicates progression to heat stroke or a body temperature that remains elevated after your symptomatic treatment. Be very careful of patients in special populations such as pediatric or geriatric patients as well. Heat stroke is that true emergency. Recovery really depends, a lot like hypothermia, on how long they've been in that particular condition and how rapidly you can respond and treat them. In the field, the emergency treatment is to lower their body temperature. So we can just keep in mind what those mechanisms are, and notifying EMS is going to be really important because this is a life threat. And so we can move the patient to a cool shaded environment, remove their clothing, and this is going to help with those key ideas of convection and evaporation and radiation. If you remove their clothing, you can help with radiation. If you're able to keep the skin wet and have moving air, that's going to help with convection and evaporation. It's going to lower their body temperature. Conductive cooling, that is contact cooling, our 4th mechanism for heat transfer, is effective as well. If you can put an ice pack into the armpit or the groin where some of the blood vessels are very close to the surface and so it has that contact effect, that can be done as well. We want to check the patient's temperature frequently to see if our interventions are working, if we're lowering the body temperature. When the body temperature reaches about 101, we're still elevated, but not as dramatically, so we can taper off the cooling efforts. And we want to be sure still to follow through in terms of evacuating that patient and handing them off to a higher level of care. Differentiating between heat exhaustion and heat stroke is summarized for us right here. They're both going to be due to high environmental temperatures. They might be associated with exercise, but the real key is right here around that altered mental status that we see in a patient who has heat stroke. The internal temperature, kind of 104, is sort of the boundary between those two. They're both going to be tachycardic with an elevated pulse. But hopefully, in the case of heat exhaustion, our field treatment helps that patient. We need to make sure that we evacuate the patient in the case of heat stroke. Being active in a hot environment requires a lot of preparation. Under preparation just really predisposes you to some of those heat illnesses. And remember, some of these acute problems, especially heat stroke, can be deadly.